What's up, Ninja Nerds? In this video, we're going to be talking about the Delta variant. This is one of those variants of concern that we're starting to see a lot more cases, a lot more hospitalization and death with. So what I want to do in this video is talk about the Delta variant, and along the way, while we're going through this, utilize articles and data that we provide for you. We'll have a document down in the description box. Click on that so you guys can follow along to all the articles and data that we talk about throughout this video. So let's dig in and let's talk about the Delta variant. All right, Ninja Nerds, so let's talk about the Delta variant. One of the variants of concern that's really becoming the more prevalent is becoming this variant that we're seeing a lot more cases of across the world. Now, there's a bunch of different variants of concern, and then we have Alpha, that's the original kind of UK variant. We have Beta, that was one of that South African variants. We have Gamma, which was the Brazil variant. We have Delta now, which is becoming the real prevalent one. And then we have this Epsilon one that we're seeing in parts of California that's starting to kind of also increase. But what is it about this variant, the Delta variant, that we're really kind of seeing a little bit more prevalence in? Well, obviously all of these variants of concern, they're altering a particular component of that SARS-CoV-2 virus, and that is this S protein, the spike protein. There's particular mutations that we're seeing within the spike protein that increases the virus's ability to enter into cells within our body, replicate, and potentially evade the immune system. So this virus, in the same way that we talked about in the original kind of COVID video, it still gets kind of spread through respiratory secretions, coughing, sneezing, touching different surfaces, and then someone going on and touching that surface and touching part of their face. When it gets spread through the respiratory tract, if we were to kind of take, let's say it gets spread through the respiratory tract and we zoom in kind of at the cellular level at the alveoli, what does it kind of do? Well, we've already talked about this in so much detail. But really, this virus, that SARS-CoV-2 virus, particularly in this case the Delta variant, it utilizes very specific types of proteins to enter into cells in the body. And if you guys remember, we will talk about this more, but that's that ACE2 receptor that we're seeing. And the virus will bind onto that ACE2 receptor, which will facilitate the entry of the virus into these cells. And then what do we know? Well, we know that these cells start to become damaged, they start to become injured. And what's the problematic issue with this? Well, as they get injured, that triggers your immune system to come to the area of where that injury is. And so particular white blood cells will come to the area. When these white blood cells come to the area of where a lot of this injury is, what do they start to do that causes a lot of this nasty issues? There's that increased cytokine storm that we talked about before, right? Where they can increase the production of particular cytokines like interleukin-1. They can increase their production of interleukin-6, which seems to be one of the really problematic ones, and even increase the concentration of the production of TNF-alpha. And we know that these cytokines actually cause a significant amount of inflammation. They can lead to pneumonia, ARDS, multi-system organ failure at the worst case scenario, as well as even increasing prothrombotic processes. Now that's kind of the nasty effect of this, right? But let's take a look here for a second and actually see how does this Delta variant, what are the particular mutations and what particular components of that RNA are mutating that allows for it to easily enter into the cell, replicate, and then evade the immune system. Let's come up here for a second. What is it really about this Delta variant that it's having these mutations, that it's making the spike protein a little bit more nasty, if you will? Well, if we take a look here, let's say that we kind of look at the viral RNA really of this Delta variant. So let's say that here we have that RNA, right? Well, RNA is going to be utilized to make a particular protein, right? And then a particular sequence of it will be utilized so that we can make the spike protein. Okay, now the spike protein, again, is really important because it's what binds to the ACE2. It's utilized for the viral entry into the cell. So it's a very important protein. Well, we modify it in a particular way. What happens is there's particular mutations that occur along the way, and this happens as more viruses infect more people. As that virus continues to replicate more and more and more, it has the ability to produce mutations. That's just a process of increased replication. So what happens is we see this L452R and T478 K type of mutation. And what that's doing is it's modifying the S protein in a particular way where it has very, very, very specific capabilities. What are those capabilities? Well, one of the things that we see here is that they modify the S protein in a particular way where it has increased binding capability. To what? To the ACE2 receptor. Well, here's your ACE2 receptor right here. So that ACE2 receptor, there's increased binding. If you increase binding to that ACE2 receptor because you have a higher affinity of the S protein for it, you increase the actual entry of the virus into the cell. The other thing is there's increased furin cleavage. There's a very special protein here that helps in cleaving a particular part of the protein and allowing for entry of the virus into the cell. And that is called the TMPRSS2. And this protein right here is designed to be able to cleave particular points and increase entry. Well, this S protein modification works in a particular way where it increases furin cleavage and increases the entry of the virus into the cell. If the virus is able to get into the cell easier and quicker, it then can use the cell's machinery, like the different proteins and organelles, to make more virus. If you make more virus, you increase viral replication. And if we increase viral replication, we can have higher loads of the virus that could potentially be within the body and increase transmissibility, potentially severity, so on and so forth. The other aspect is that when you make more viruses with the modifications in the S protein. So now when they get into the body and they start replicating and infecting other different cells in the body, there's particular modifications in this S protein. And what it's been found to do is, within our cell we have very specific types of cells called plasma cells. And these are really beautiful antibody producing factories, if you will. When they produce these antibodies, what we're seeing is these mutations may allow for antibodies to be less effective at binding and neutralizing the S protein on these viruses. But what we don't know is, what about the T cells? Those cytotoxic T cells and helper T cells, with memory cells, we don't know how or if these protein mutations are allowing for an evasion of those aspects of our immune system. So that's something that we need more research on. But that's the things that I want you guys to understand. Now, let's take a look at some data that we have that supports what we just talked about. All right, Ninja Nerds, so we're going to take a look here at the literature to support what we were talking about on the whiteboard. So in the description box, we're going to have a document of all of our references. This first one is point 1A, so this is a table from up to date. And it just goes over the variants of concern that we see here that we talked about: alpha, beta, gamma, delta, and epsilon. With the most concerning one, that it'll become the most dominant variant, is the delta variant, also known as B.1.617.2. And what we see that's kind of making this variant a little bit more nasty is these particular mutations in these particular parts of the RNA. And what that allows for is it allows for the virus to be able to bind to the ACE2 receptor quickly. It allows for it to have a higher affinity for that, more furin cleavage sites, more replication, and potentially evade the immune system. And as we'll see in a second later, that there is an increased transmissibility of this variant. So much so than alpha, potentially 64%, which we'll see in a little bit. So that covers this first part. The second part that we're going to take a look at is the viral load, which we'll have a couple points to talk about there. All right, so we have an idea a little bit about the Delta variant and how it's kind of a little bit nastier. But what we need to understand is, with all that stuff that we just talked about, what can that do? What's the problem with that? And so when we take here and look at the virus and its ability to have higher loads of the virus, because there's increased replication, there's a lot of things that are increasing the factor of having more of that virus within your respiratory tract. What we see is that viral load is almost 1,000 times higher of an actual viral load with Delta and compared with like the ancestral strain and maybe even with Alpha. So let's take a look at some data that supports that statement. All right, so we talked about viral load and how viral load is much higher with the Delta variant in comparison to the Alpha variant. If we actually look look here from some literature from up to date, this is actually going to be 2A within that document that we have for in the description box. We can see here that an unpublished study of an outbreak in China suggested that the initial respiratory tract viral RNA levels are about 1,000 times higher with the Delta than were observed with the ancestral virus circulating during the first phase of the pandemic. And so that's pretty significant to think about the viral loads being that much higher. And what's interesting is that this could actually be in those who are vaccinated or unvaccinated. And so that's another interesting point to take away from this. All right, so that covers viral load for the 2A. Let's use the other aspects of the literature from 2B and 2C. All right, so we're looking at this next thing here, which is the leaked CDC report. We'll be referring to this a lot. But if we take a look here, again, this is going to be covering 2B and 2C for that part in the description box for that document of references. So if we scroll down here, we're going to see a part here where it discusses how the Delta variant infections are associated with much higher viral load and duration of shedding. And this is based upon all the published evidence that we see here. Okay, so that takes care of that. So now let's go ahead and move on to the next thing that we want to talk about here, which is the transmissibility, which is going to be in the third part of that references that we're going to discuss. The other thing that we need to understand is because we have more of this viral load and this virus is really, really nasty, it may have the ability to be more transmissible and contagious and spread to other people. We actually see that it's about 64% more transmissible than the Alpha variant. And what else can support this? If we take a look here, if you guys remember, we talked about this within the original kind of SARS-CoV-2 COVID video, was that there's something called the reproductive ratio. So how quickly this virus can spread and transmit to other individuals. I think this gives us a pretty good idea of how transmissible this virus, this Delta variant is. If we look here, let's say that there's just one person in pink here, right? It has the ability, this Delta variant has an R0 from 5 to 9. Let's go with the max just to really give the significance of this. That means that this individual can infect, but if he becomes infected with the Delta variant, he can infect up to 9 people. Those 9 people, if they're around a crowd of people, they can infect another 9 people. So we could go with one person infecting upwards of 81 individuals. That's very significant. So we see the R0 of 5 to up to 9, almost as transmissible or contagious as chickenpox. If we compare that to what the original R0 was, it was about 2 to 3. So one person can infect up to 3 individuals. That's a significant jump here. Let's take a look at some data that supports this. All right, so we're taking a look now at the third part within that references document, which is talking about transmissibility. So we already discussed that it's about 64% more transmissible. And so if we look here at 3A, B, and C within our references document, we're going to go down to about page 8. And on page 8, there's a nice little statement that we have highlighted here for you within the discussion that again shows that the study found a 64% increase in the odds of household transmission associated with the Delta variant compared to Alpha after they adjusted for vaccination status and sex and ethnicity and so on and so forth. So this is a pretty interesting kind of result that we see here with transmissibility. All right, let's take one more look. Let's go back to that leaked CDC report at 3D and again just provide some more support for this increased transmissibility with the Delta variant. All right, so let's take a look back at this leaked CDC report. So as we come down here in the CDC report here, we see the transmission of Delta variant versus like the ancestral and other kind of infectious diseases. So if you look here in this nice little beautiful graph, we have a y-axis, and this kind of gives us the fatality rate of these viruses or infectious kind of pathogens. And as we go up, it's obviously more deadly. And as we are on the x-axis, this is kind of just telling us the average number of people that can be infected by each person. And so this is kind of just showing the spread or transmissibility of the virus. And as you can see here, they have a kind of a blanket statement here that Delta variant is way more transmissible than all these other viruses here on that left side. And if you kind of look at the reproductive ratio that we can kind of say based on the x-axis, it goes here at 5 all the way to about probably 9. So we can say that the Delta variant has an R0 or a reproductive ratio of about 5 to a max of 9, meaning that one person can infect up to about 9 individuals. And this makes this about as transmissible or contagious as the chickenpox, which is pretty intense if you compare that here. So again, this is just, again, supporting the data that we have there on the whiteboard. So now let's go ahead and talk about severity in the next part, where we'll talk about how nasty this Delta variant can be in comparison to the other variants of SARS-CoV-2. So not only do we understand the viral load, the transmissibility, but what about severity? We see that there's a thought that this could be potentially higher cytokine storms. It's very contagious. It can cause more severe infections. We have some data that we're going to take a look at that shows that it could actually have an increased hospitalization rate compared to the other variants of about 2 to 2.5 times higher hospitalization rate and death rate. So it does seem that it can be more severe infections, whether that's related to the cytokine storm or some of these other factors evading potentially the antibody or immune system. That's something that we have to elucidate more. So let's take a look at some data that supports this. All right, so now we're going to talk about severity. We talked about this a little bit within the whiteboard. Again, let's provide some evidence to really support this from the leaked CDC report. Again, this is going to be at point 4 within that document. We're going to be looking at 4A, B, and C here. And again, this is just kind of supporting our data here that the Delta variant may cause more severe disease than the Alpha or all the other ancestral strains. And there was some published evidence from Canada, Singapore, and Scotland that, again, as we see here, higher odds of hospitalization, admission, ICU admission, and death. We see higher odds of oxygen requirements, so potentially more pneumonia, ARDS kinds of cases, ICU admission or death, and higher odds of hospitalization with the Delta variant. Could this be related to, again, that increased transmissibility, the increased viral load, or maybe just more cytokine storms, less effectivity of our therapies? It's not completely sure yet. But again, as we come down to the summary, we have a nice blanket statement here that is, again, just telling us that the Delta variant is likely more severe than all the other ancestral strains. All right, so now we take a look at 4D, just again to provide us some more data to support this severity of the Delta variant compared to the other ancestral strains. All right, so back to our table 1 from up to date, but again, this is going to be 4D within that references document. Again, we're talking about the Delta variant, also known as B.1.617.2. And if we come over here to, again, the known attributes, we just see here this blanket statement of potential increased severity based upon the associated hospitalization rate that we see with the Delta variant, particularly in comparison to the other ancestral strains. So that covers this part. Let's move on to another one, 4E within that document, that again supports the severity of Delta variant. So here is another article from The Lancet. This is again 4E within your references document. And if we come over here, we're talking about the Delta variant of concern in Scotland. It shows here that the Cox regression analysis for the time to hospital admission found that the S gene positive cases, again, this was particularly for the Delta variant, were associated with an increased risk of COVID-19 hospitalization admission, a hazard ratio of 1.85, so almost 2 times that of someone else who had another type of ancestral strain. We see that this is almost 2 times higher risk of hospitalization rates in comparison to the other ones. And then you can see when we compare it to the S gene negative cases after all the adjustments that they provide. So again, definitely some support there for increased severity with Delta variant. So let's move on to the next part of this 4F to again provide a little bit more documentation in support of the severity of Delta variant. All right, so let's look at the next document. If we look at 4F within our description box, you have all those references again. We're going to take a look at the Public Health of England, Technical Briefing 14. We'll be looking at a lot of these technical briefings. And again, we're primarily looking at these SARS-CoV-2 variants of concerns that were under the investigation in England because UK had a pretty significant breakout, particularly with the Delta variant. And if we want to talk about, again, the Delta surveillance and we want to talk about severity, we're going to come here to page 46. And so when we look at here, the data coming from England, they utilized what's called the Cox proportional hazard regression. And there was a significantly increased risk of hospitalization within 14 days of the specimen date. And again, we see here about 2.61. So about almost a 2.6 times increase of hospitalization in those who were tested positive for the Delta variant. And again, you can see here for the Delta cases compared to the Alpha cases. So pretty significant increase in severity when we talk about this variant. All right, so now what we're going to do is we're going to start talking about the prevalence or the population that was primarily affected by the Delta variant. So let's go ahead and go into that, which is going to be the 5th component or 5th number within the document on the references in our description box. Lastly, what I want to talk about is who is prone to these infections? And I think this is an important thing. So the Delta variant, what we're seeing is we don't have a lot of US studies to really kind of provide a lot of evidence right now. So we're depending upon more international studies, especially the UK, because they had a pretty decent outbreak or breakthrough infections with the Delta variant. And what we saw from some of their studies, and we'll take a look at them, is that we see a very significant increased rate of infections among those that were less than 50 years of age and unvaccinated, okay? Now, what's really, really important to understand is that when we actually also look at the data, we see that there was also a lot of incidences of those who were greater than or equal to 50 years of age with underlying comorbidities, immunosuppressed. And here's what's really interesting. We see that the severity and hospitalization rate for these individuals was about equal, regardless if you were vaccinated or unvaccinated. So what we take away from that, I think we still need some more studies. But that's an aspect on prevalence. Let's look at some data that supports that. All right, so now we're on the next part here where we're talking about the population affected, or kind of like the significant prevalence of this Delta variant. And we're looking at the next part, which is 5A within that document. This is looking at the React 1 round 12 report. And so if we go down here to about page 5 within this document, we see a nice little part here that we highlighted for you guys within the discussion. And what it says here is that we observed that the growth was being driven by younger age groups with 5-fold higher rates of swab positivity among younger children, ages 5 to 12 years old, and young adults 18 to 24 compared to those that were aged 65 years and older. And here's where it's really interesting. There is a 2.5-fold higher rate among those below 50 years of age compared to those with 50 years and above. So we're seeing a lot of individuals less than 50 years of age who are actually contracting or being infected by this Delta variant, which is very, very interesting. Okay, so let's go ahead and move on to the next document here to again support the population, the prevalence of this virus, which is going to be 5B, and we'll take a look at the technical briefing 19. All right, so we're taking a look again at this Public Health of England technical briefing 19. And again, looking at the SARS-CoV-2 variants of concern in England, because again, when UK got hit pretty hard by this Delta variant. And again, this is going to be 5B within that document of references. So if we come down here to our table of contents, we're going to look at variant prevalence. Okay, now it's kind of a little bit weird. We have to come up here a couple pages. We want to get to this nice little table here on page 18. And if we look here, we see table 5. This is basically telling us the attendance of emergency deaths and emergency care and deaths by vaccination status among all of those who tested positive for Delta. And so if we look here, the Delta cases, particularly again, we have variant here, we're looking at Delta cases. We see here the age group less than 50 years of age. We had a total individuals here of about 205,549. And if you look at those who actually were infected and unvaccinated, what do you see? A very large proportion in comparison to those who received 2 doses of the actual vaccine, potentially Pfizer or AstraZeneca. And then again, much, much more than those who received even 1 dose, or here, again, 1 dose. So we're seeing a very large individual, a number of individuals infected who are unvaccinated and less than 50. And this is, again, those who are infected. If we come down here a little bit and we look at the cases that actually required like hospital admission, we see here, again, less than 50 years of age. If we scroll over here from 1,529, look how many of these were unvaccinated and compare that to those who were actually vaccinated. Much, much higher. And so you do see a significant increase in this number of cases, particularly less than 50 and unvaccinated with this Delta variant. Okay, so now let's go ahead and move on to the next part, which is going to be looking at the CDC's website and talking, and again, this is 5C, again, providing more supporting evidence about the prevalence in the population affected by Delta. All right, so now we're looking at 5C within that references document we have for you guys. Again, this is just kind of a blanket statement from the CDC's website. And it's just, again, it supports here that some data suggest that the Delta variant might cause some more severe illness than previous strains in unvaccinated individuals. And we already kind of have an idea from that UK study that it seems to be those less than 50. And again, supporting that concept here that unvaccinated people seem to have the highest rate of infection and seem to be the greatest concern in those that are being affected by the Delta variant. Okay, so now let's move on to the next study here. We're going to look at this article from the New York Times, really giving us an idea about how unvaccinated individuals seem to be the ones most affected by this Delta variant. And again, that's going to be 5D within that document of references. All right, engineers, so this is a very interesting kind of article from the New York Times. If you guys go into the document again, 5D, you guys will see that there's a link for the New York Times. We just took some screenshots of some of these graphs. So again, what we're looking at here is we're looking at 5 states within the United States with the lowest vaccination rates. And we can kind of see here the number of cases, and we see here the number of hospitalized. If you look here, Alabama, Arkansas, Louisiana, Mississippi, and Wyoming have relatively low vaccination rates. And again, look at the cases. You kind of see this sort of exponential growth. You definitely see it here in Arkansas. You see it kind of going up here for Louisiana. You see it going up for Mississippi. And again, you see this going up for Wyoming. Now, again, look at the actual hospitalization though. Look at this. You see it going up, significantly going up, going up. We see it going up here, and again, starting to go up here. So what we can kind of assume from this information here is that those with lower vaccination percentages within a population seem to have higher cases of Delta variant infections and also higher hospitalization rates. To further support this, let's look at the actual 5 states with the highest vaccination rates. And again, you see Connecticut, Maine, Massachusetts, Rhode Island, and Vermont. Around 60% or above with their vaccination status within the population. Again, here's the number of cases and here's their hospitalization rates. This is pretty interesting. Look at the number of cases. You don't see that exponential growth that you saw with the low ones. You see very low ones here in Maine, low cases, low number of cases, and almost no cases here in Vermont with the Delta variant. And then again, look at the hospitalizations. It's going down. It's not trending back up, going down, and it's not trending back up here. So pretty suggestive that, again, the population that we seem to be affected here is not only those less than 50 years of age based upon the UK study, but those who are unvaccinated and in populations that seem to have lower vaccination status. Okay, so now let's look at another study. This is going to be 5E within the documents of references. This is going back to that leaked CDC report to, again, support the population or prevalence of this virus. So let's take a look at another, going back to the leaked CDC report, 5E within that document of references. So again, we're going to move down here. And again, this document is really good at kind of providing a summary of a lot of information right now. So if we come here to this nice, beautiful table here. This gives us here disease incidence. So again, kind of number of people infected, hospitalization, and death. And here in green, we're going to see those that are unvaccinated here in green. And then those here in blue, we're going to see those that are fully vaccinated. And when you look at this, my gosh, there is an 8-fold reduction in those who actually develop the disease who are vaccinated. And then again, there is a 25-fold reduction in those who are hospitalized who are fully vaccinated, and a 25-fold reduction in death in those that are vaccinated. And so another way we can say this is that there is an 8-fold increase in disease in those who are unvaccinated, a 25-fold increase in hospitalization and death in those that are unvaccinated. Now, we have to look at all the information. We can't just say that it's only those who are unvaccinated that still can actually develop the disease or become infected by this Delta variant. We are seeing those that are greater than 50, generally higher age groups with underlying comorbidities who have immunosuppression of some kind. We are seeing that those individuals can become infected, as well as can have higher hospitalization rates. So when we talk about, again, severity with this condition, we can see higher severity, higher hospitalization rates in those individuals who are older, greater than 50 years of age, and again, have underlying comorbidities. So that is an important thing to take away from this. All right, so let's talk about the next thing, which is the symptoms of COVID-19, particularly with the Delta variant. Have they changed at all? Is there any differences within them? All right, so let's talk about the symptoms. So in our original kind of COVID-19 video, we talked about there was a very wide array of symptoms, and it keeps changing depending upon the variant. So one of the things that we're going to talk about is there any particular symptoms that are different with the Delta variant that we're seeing more of than we're seeing with the other variants? So when we talk about this symptoms, generally one of the worst case scenarios is that if it affects the lower respiratory tract, It can start leading to things like pneumonia. Worst case scenario, it actually becomes more inflammatory, that it leads to acute respiratory distress syndrome. And we even see this thing where there's potentially increased hypercoagulability. There's more coagulation issues to where it increases the risk of forming clots within that pulmonary circulation, leading to pulmonary emboli. Now, the other thing is that some of the symptoms that you generally would see in someone with these lower respiratory tract infection types of symptoms is you may see fever, but you may also see cough, some shortness of breath that may be at rest or on exertion. Okay? The other thing is that we see that the actual virus has the ability to infect particular parts of cells in our heart, particularly those within the myocardium and within the pericardium. And so we start seeing a viral myocarditis and a viral pericarditis, which again could lead to some type of pain, chest pain, but also lead to shortness of breath as well. And again, you could also see some elevations in like particular enzymes like troponins. What we're starting to see though, and again we'll look at some data from this, from the American Society of Microbiology, that there is primarily more upper respiratory tract infection types of symptoms that seem to be within the mild, more symptomatic cases. And that tends to be headache, runny nose, sore throat. Less common that you're seeing with the Delta variant is loss of smell, anosmia, and loss of taste, ageusia. The other symptoms that we're starting to see, which is a little bit more interesting, is that we're starting to see maybe some involvement of the inner hair cells leading to hearing impairment. Also, maybe through some type of hypercoagulability or process that we don't understand, there also may be some tissue gangrene or necrosis. We're also seeing, again, fever to be relatively common, and another one is GI upset. The last thing that I want to talk about here is that we have this term called long haulers or long COVID symptoms. Is there long COVID symptoms possible for someone who gets infected with the Delta variant as compared to the other ones? It seems that that could be possible, but I think we need some more data again to really support that. But we define someone who has a long COVID kind of hauler or symptoms as having these COVID symptoms, some of that we talked above, with having evidence of COVID infection for greater than or equal to about 12 weeks. Okay, so let's look at some data here now to actually support some of these symptoms that we talked about. All right, engineers, so we just talked about symptoms of the Delta variant. It seems that a lot of them are pretty similar to the ancestral viral strains of SARS-CoV-2. But again, if we kind of look at what we talked about, how there's particular symptoms that tend to be more common, in 6A from the American Society for Microbiology, here we have a question: is the Delta variant more dangerous than other variants of concern? And if we look here, we highlighted for you that it tends to be fever, headache, sore throat, and runny nose, while cough and loss of smell aren't as common. So again, these tend to be kind of that upper respiratory tract type of infection symptoms, seem to be a little bit more common. However, there can be more serious symptoms, including hearing impairment, severe gastrointestinal issues, and even blood clots leading to tissue death and gangrene. But again, there's still more research to see. Is there, again, more cases of ARDS? Is there more cases of pneumonia, multi-system organ failure? That's still kind of being assessed at this point in time. But again, as we've seen already, there is higher hospitalization rates that we see with the Delta variant. All right, so that covers our symptoms. Now, in the next part, we're going to talk about the treatment. How has the treatment changed? And then 7A and B, we'll talk about the treatment, particularly in those individuals who have the Delta variant. How do we treat them, whether they are not hospitalized, and as we go through their severity, how does their treatment change? All right, engineers, so let's talk about the treatment. Now, regardless of this being the Delta variant or some other kind of SARS-CoV-2 variant that causes COVID-19, the treatment is relatively the same, but there is some slight modest kind of reduction in efficacy in one of these categories. But in general, if someone has a very mild to moderate kind of symptomatic disease of COVID-19, One of the biggest things is that if they are not in a high-risk category, you don't have particular comorbidities or diseases or immunosuppressive conditions that put you at higher risk, sometimes the therapy is just very important supportive therapy. Staying home if you have symptoms, utilizing fluids to stay hydrated, monitoring your pulse ox, monitoring your fever, taking Tylenol if you have a fever, wearing your mask around other individuals, optimizing your immune system with vitamin D. A lot of these things are very important supportive therapies with a lot of emphasis of really trying to reduce the transmission of it by isolating, quarantining, and wearing your mask. However, for those that have that mild to moderate disease, they don't need to be admitted into the hospital, but they are at high risk of progression of the disease because of particular comorbidities, immunosuppressive condition, age. There is particular therapies that were effective for alpha, but are showing to be a little bit less effective with delta. There may be some resistance here, but there was this monoclonal antibody therapy that we saw relatively effective in high-risk groups, and those that are mild to moderate symptoms, outpatient therapy. And these are your monoclonal antibodies that we show here, but again, what we're starting to see though is that delta is showing some resistance against these. And we'll talk about some data in a second. Let's say that we go to the next part of this, where the patient is sick enough that they need to be hospitalized, admitted into the hospital, but they don't really need to be in the ICU because they're not really requiring any oxygen therapy. We're just monitoring them. What is the therapy there? We see, again, remdesivir could be utilized, but again, only in those high-risk groups that have a very strong chance of them progressing into a more severe case, okay, and eventually leading them to the ICU. So remdesivir works by what particular way? It works by inhibiting, do you remember that enzyme? The RNA-dependent RNA polymerase, which is helpful for making more of those viral copies. It may inhibit that process. Let's go to the next step. If we go to the next step here, we have those who are hospitalized but are requiring oxygen therapy, but it's not like higher levels of oxygen. We can utilize things like nasal cannula, where you only really go up to like 6 liters, or like a non-rib breather mask. Okay, or other kind of low oxygen therapies, not as much high flow oxygen therapies. What are some of the drugs that we've seen to be relatively effective here? Well, generally, there's two parts here, where you only use remdesivir or you only use dexamethasone, but the combination of them seems to be the best effectiveness, seems to show the most efficacy against these individuals who are hospitalized and are requiring oxygen. But either way, if you're only getting remdesivir, you have to have very low O2 requirements. You're not requiring much of these actual therapies to actually maintain a particular oxygen saturation or lower your work of breathing. And again, remdesivir works by inhibiting the RNA-dependent RNA polymerase. The other drug is dexamethasone. This is a corticosteroid. Corticosteroids are very good at reducing just a lot of that cytokine storm that we see. And so it may be inhibiting a lot of those cytokines that we were talking about before, really reducing a lot of the effects of the cytokine storm. But again, you only use this by itself when the combo isn't actually possible, okay? But the best combination is actually giving remdesivir and dexamethasone to this category of group, along with supportive oxygen therapy that we talk about here. One quick point before we move on to the next aspect of the treatment algorithm is that when individuals start to require more oxygen therapy, they're hospitalized and they have positive COVID PCRs, their risk of hypercoagulability increases, right? So where they can develop pulmonary embolisms. And so because of that, generally as people start to progress to the point where they're actually requiring more high flow, they're getting to this point where they need to be ventilated mechanically, we start kind of incorporating anticoagulation to reduce the risk of them developing pulmonary embolisms. And so utilizing things like low molecular weight heparin, or if they can't utilize that, fondaparinux is another type of heparin kind of analog that you can utilize here. So now, after we've anticoagulated them, let's go on to the next part of this therapy regimen. All right, so the next aspect, we're at those who are hospitalized, right? They're requiring higher levels of oxygen, particularly high flow, or what's called non-invasive positive pressure ventilation. What does that mean? Well, high flow oxygen is there's different types like OptiFlow, but you're giving a very high, you can give a very high concentration of oxygen. You can give up to 100% FiO2 on this one, but it just gives a very large portion portion of it. You can give it up to 50 to 60 liters per minute. The other option is what's called BiPAP, and this is a non-invasive positive pressure ventilation where you can give, again, 100% of oxygen. You can give them also PEEP, positive and expiratory pressure. Really helps to recruit and open up those alveoli in people who have pneumonia or starting to progress into ARDS. And it also gives you some good pressure support to allow for helping to get air into the lungs and really opening up those airways. So in people that are requiring this, there is particular medical therapies that we can institute. One of those is you can give remdesivir. Generally, you don't give remdesivir on its own. You could also, and again, remdesivir works by inhibiting the RNA-dependent RNA polymerase. You can also give a couple other medications. Dexamethasone, again, you don't really give this one by itself. Tocilizumab and baricitinib, you can add those on. So tocilizumab and baricitinib, you can add on. What is the best kind of treatment when a person is on that therapy? What we've seen is a particular combo. One is remdesivir and dexamethasone, but if someone has a contraindication to being on dexamethasone, steroid, you give them remdesivir and baricitinib. Now, either way, with one of these combos, remdesivir and dexamethasone, or remdesivir and baricitinib, sometimes you can add on that tocilizumab. Okay? So again, this is the therapy that we utilize in those that are hospitalized and requiring higher levels of oxygen. What about those that don't get here? They have increased work of breathing, they're still hypoxic, they're starting to have some issues, and this therapy is failing. We start to get into the worst case scenario where someone has to be mechanically ventilated or put on ECMO, extracorporeal membrane oxygenation. So whenever we get to mechanical ventilation, it's important that these patients can develop ARDS, acute respiratory distress syndrome. There's an ARDS-NET protocol that says how we should effectively, and a big important thing here, protective-wise, prevent lung injury in someone who has ARDS. And so we use tidal volumes that are a little lower, 6 to 8 cc's per kilogram per predicted body weight. Plateau pressures, you want to keep those relatively low, less than 30 centimeters of water. And ideally is to keep those alveoli stented open and recruitable, we want to keep PEEP greater than 5 centimeters of water. If this doesn't work, and the particular score called the McMurray score is actually going to be increased, we can do what's called ECMO, extracorporeal membrane oxygenation, and that may be an indication for putting someone on ECMO. And ECMO is basically you're taking blood from them, usually from a venous structure, oxygenating it via an oxidizer, and then sending it back to their actual blood circulation via like the superior vena cava, so that you can pump more oxygenated blood through the body. Okay? Now, if someone is receiving these types of ventilation strategies, what are the drugs that we can generally give? Dexamethasone seems to be the best one, but you can also add in tocilizumab, which again is that interleukin-6 inhibitor, if it's within 24 hours of admit. These two drugs seem to be the ones that have been shown to reduce mortality more than a lot of the other ones, particularly dexamethasone. Okay, so now that we have all this information, let's take a look at some data from the NIH as well as up to date to really support all this that we're talking about. So now we're on the 7th part of our document within the references. We're talking about treatment, right? And again, we're looking at two of these articles, well, 2 points within the article from the NIH, the National Institutes of Health. And it gives us the therapeutic management of non-hospitalized individuals and those who are hospitalized. And again, it's based upon disease severity, as you can see here. So I want to draw your attention to this particular one here, which is the outpatient management. Those aren't that are requiring any oxygen therapy, but particularly individuals that are high risk of disease progression. There's a bunch of factors and comorbidities and particular things that puts people in this high risk category. We're not going to go through that. But if they fit into this high risk category, there's particular monoclonal antibodies that you can see here. IMABs is how I like to remember. If you guys want to play hangman and never lose, just use these guys. I don't think anybody will ever guess them. But as you can see here, the bamlanivimab plus this other guy here, anything that ends in IMAB, these tend to be relatively effective against the previous ancestral strains of the SARS-CoV-2. And again, particularly in those who are at high risk. What we're seeing now, though, and we'll provide some data for this, is that these monoclonal antibody therapies may actually not be as effective in the Delta variant. There may be some resistance to these monoclonal antibodies with the Delta variant. But again, these right here tend to be kind of the first line therapy for those at high risk of disease progression. I'm an outpatient. As we go to those who are hospitalized, again, you have this disease severity as we go down. Those that are hospitalized but don't really require any oxygen, there's a very high level of recommendation for dexamethasone, a steroid. And there's insufficient evidence, but sometimes there can be the utilization of remdesivir. Now, those who go to requiring some type of supplemental oxygen, maybe a nasal cannula, a non-rebreather, we can provide remdesivir, dexamethasone by itself, but the desired combo is dexamethasone plus remdesivir. And then again, as we go to hospitalized that are starting to require potentially BiPAP or high-flow nasal cannulas, we potentially like to use dexamethasone, or again, dexamethasone plus remdesivir. And then as their oxygen requirements begin to go up, we add on these other particular molecules here like tocilizumab or baricitinib. And then as you go up to the last part here, in those that are hospitalized requiring mechanical ventilation, RSNet ventilation, or extracorporeal membrane oxygenation, ECMO, we generally like to use dexamethasone, but generally those within 24 hours of admission to the ICU, dexamethasone plus this interleukin-6 inhibitor, tocilizumab. And again, this is kind of just supporting all the stuff that we talked about on the whiteboard. Let's take a look, though, about this monoclonal antibody from up to date and how there is a potentially increased resistance against this therapy in outpatient studies. So let's take a look here at 7B. Okay, this is going back to table 1. Again, with an up-to-date, we're back at this. And I just wanted to kind of just provide some evidence here of why we're seeing this reduction in efficacy of those outpatient utilization of the monoclonal antibodies against the Delta variant. So again, look at alpha for a second. Here's the alpha variant, the UK variant B.1.1.7. And if we come over here to the known attributes, we see that there is this minimal impact on neutralization of the monoclonal antibody therapies. Remember the IMABs? All of those, there was really no change in their susceptibility. You can utilize these, are relatively effective in those that are high risk. If we come down to Delta, B.1.617.2, come over to the known attributes, we're seeing a potential minimal reduction in neutralization by the monoclonal antibody therapies, seeing that they're potentially not as effective in those with the Delta variant. So very interesting thing to see there with this guy. All right, so now let's move on to the next part, which is asking the question, are vaccines really good and effective at preventing the infection, hospitalization, and death with the Delta variant?
All right, so now let's talk about a very important point and probably one of the most important points within this lecture on the Delta variant and in general with COVID-19. What seems to be very effective without having to get to this point when someone's really getting sick is vaccination. There's a lot of efficacy with these vaccines. Now, granted, the data is showing that there is a minimal to almost moderate reduction in the vaccine's effectiveness against like symptomatic diseases, like just generally some of those mild symptoms to almost asymptomatic cases. And so we'll look at some differences there. But what we are seeing though is that the infections, okay, the number of symptomatic diseases that those who are vaccinated, usually the vaccine is way more efficacious in compared to those that are unvaccinated. So you're seeing more individuals who are actually contracting COVID, the Delta variant type regardless, who are actually developing symptomatic disease who are unvaccinated in comparison to those that are vaccinated. That doesn't completely hold true though in particular age groups like greater than or equal to 50 years of age with underlying comorbidities. It actually could be almost equal. What is a big thing to take into consideration is the efficacy against hospitalization and death. That's what we're seeing. We're seeing that these vaccines aren't the best infection blockers, but they're very good at acting as a hospitalization and death blocker, which I think is very important and profound in effect, right? So we're seeing a very high efficacy, greater than 90% efficacy of these vaccines against these two aspects here. Way higher than those who are unvaccinated, but very important to remember, we're again seeing this, the data is more suggestive that it's actually in those less than 50 years of age as comparison to those that are greater than or equal to 50 years of age with more comorbidities. It actually could be almost about the same. And again, that's going off of some of the UK studies. So that's talking about vaccine efficacy. Let's actually look at the data that actually kind of supports a lot of this.
All right, engineers, so we talked about vaccine effectiveness on the whiteboard, but let's provide some data to really kind of put some support behind these blanket statements. So again, if we look at 8A within the reference documents we provided for you guys, we're going to look here at the New England Journal of Medicine, the effectiveness of COVID-19 vaccines against the Delta variant. If we come down here and just look at the results from the abstract, we can see here that the BNT162b2, which was the Pfizer BioNTech vaccine, it showed the effectiveness of 2 doses of that actual vaccine was 93.7% with the alpha variant. And again, this is actually disease incidence, being infected with the alpha variant. But when we compare that, it's 88%. So it went from 93.7 to 88% among those with the Delta variant. So we see a reduction in efficacy of this Pfizer vaccine from 93.7 to 88. So not significant, but it's still a reduction. And if we look here at this vaccine, this is the AstraZeneca vaccine. And if we look at the effectiveness of 2 doses, it was 74.5% among those who were having the alpha variant and 67%. So we went from 74.5 to 67% among those with the Delta variant. So again, a pretty decent reduction there. They're both greater than 50%, so that's beneficial. But again, we're seeing a reduction. Now, let's look at some other literature to again provide some support here saying about vaccine effectiveness. So let's look at 8b. So we're going to take a look here at 8b within the references in our document that we provided you guys. This is an article that again has not been peer reviewed yet, but again, it's the effectiveness of COVID-19 vaccines against hospital admission. So we looked at basically the effectiveness of these vaccines against infection. And it doesn't seem like they're as great against infection blocking, but they seem to be pretty good against blocking hospitalization and death. And so if we come down here into this table 1, we can see here the estimated vaccine effectiveness against hospitalization. So if we look here, we're going to have Delta here on the right, Alpha here on the left. Let's look at the Pfizer, and particularly let's look at 2 doses, since we talked about 2 doses for effectiveness against the infection. So whenever you got Pfizer, 2 doses of it, if we carry this all the way over to Delta and look at the vaccine effectiveness versus hospitalization, holy mama, 96% efficacy against hospitalization. If we again go over here to AstraZeneca, look at 2 doses of AstraZeneca, track this all the way over here to Delta, looking at the vaccine effectiveness versus hospitalization, you see 92%. So these are greater than 90% effective at reducing the effectiveness, reducing hospitalization rates when you are vaccinated. That's pretty significant. And that just goes to show that these vaccines are very good at blocking hospitalization and death, much more so than blocking the actual infection, whether it be mild or asymptomatic diseases. Okay, so let's go to the next article here, which is going to be looking at the leaked CDC report 8C, again providing some more evidence about vaccine effectiveness. All right, so we're looking at 8C within that document of references here. This is back to that leaked CDC report again, and we're going to be looking at a part here going to the Delta variant section within that. We're going to come down here to look at a nice little graph here. This is looking at the Pfizer 2-dose vaccine effectiveness for Alpha versus Delta. And so Alpha is going to be in this black color here, and then Delta is going to be in this red triangle. So if we look here at the data from the UK and Scotland, the data from Canada, and then the data from Israel. If we look here on the y-axis, this is just telling us the percentage of efficacy. And if we look here on the x-axis, in this case, this is telling us either confirmed infection, symptomatic disease, hospitalization or death. So if we look at England and Scotland, look at the Alpha variant here. Okay, and then let's now look at the Delta variant. What do we see potentially? Well, we see that the actual infection rate is much lower in comparison to the Alpha whenever you've gotten 2 doses of the Pfizer vaccine. So about 79%. Okay, now if we look at symptomatic disease, and this is what we saw within that first article, 8A from the New England Journal of Medicine, the symptomatic disease, we see that it actually is about 88% effective at preventing kind of the symptomatic mild cases of those individuals with the Delta variant. And if you look at hospitalization rate, it's still very effective. England, Scotland, the Pfizer 2-dose of that vaccine showed a 96% efficacy against hospitalization. Look at Canada. Again, 87% with the actual 2-dose Pfizer vaccine for symptomatic disease. And then if you look at this again for hospitalization or death, it's nearly 100% effective against hospitalization or death. Looking at Israel, we see that the symptomatic disease, about 64% efficacy, so that's a pretty significant reduction there. But then again, look at the efficacy against hospitalization or death, 2 doses of the Pfizer vaccine was 93% effective against hospitalization or death. And so what we're seeing again is this support that these vaccines aren't like the best at preventing infection, but they are very good at preventing hospitalization and death. And so if we come down here to a nice little summary point that they have, we're seeing that vaccines prevent greater than 90% of severe disease, but may be less effective at preventing infection or transmission. Therefore, we're going to see more breakthrough, more community spread despite vaccination. Okay, so now let's go to the next article here, which is going to be talking, 8D, looking at the effectiveness of COVID-19 vaccines. So if we look at 8D within that documents of references, we're looking at the effectiveness of COVID-19 vaccines against the variants of concerns from Canada. We're going to go pretty far down here to about table 3. We have some information that we'll point out here. And so what I want to show you guys is, again, looking at other vaccines. So we talked a lot about, Pfizer, BioNTech, and we talked a little bit about AstraZeneca, but what about Moderna? And then again, looking at AstraZeneca effect as well. And particularly this is in Canada, okay? So what we have here primarily is data after someone received only 1 dose of Moderna or 1 dose of the AstraZeneca. And all we're seeing here is their effect against symptomatic infection. So if we come all the way over here and look at Delta, what do we see? Only getting 1 dose of the Moderna vaccine was 72% effective against preventing like symptomatic infections. So not great, but it's still greater than 50%. And then again, if we look here at the AstraZeneca, 1 dose, 67% effective, again, against symptomatic infections. If we look here, though, look at the hospitalization or death that we see with these vaccine effectiveness. If we look at the Moderna after receiving 1 dose, AstraZeneca after receiving 1 dose, move over here to the Delta variant, 96% effective against hospitalization or death with the Moderna vaccine, 1 dose of it against Delta, and then AstraZeneca, 1 dose of that. Move over here, 88% effective against hospitalization or death. So we see, again, support behind this data that these vaccines are very good against hospitalization or death, not as effective, though, against the infection. And so, again, this may be the fact we have to potentially change up the vaccines. And again, that's something that needs further research. Okay, so let's look at the next document here. We're going to look at 8E, looking at a very interesting study coming from this Nature article. All right, guys, so this is a really cool study. Again, within the references, the document that we provide for you, this is 8E. I want you guys to go ahead and click on that. Again, this is looking at the reduced sensitivity of the SARS-CoV-2, the Delta variant, to antibody neutralization. And if we come down here, again, this is a very interesting thing. If you guys remember, we talked about the monoclonal antibody therapies and how they're kind of less effective in those who have the Delta variant in comparison to Alpha. Look at bamlanivimab. And again, here in this kind of blue color here that you see, if you kind of look at your little point here, here's Alpha in this kind of like bluish color here. Look at the kind of neutralization ability, pretty high. And then Delta's in red. Whoa. So again, I think that's where the information from Up to Date, where we talked about the potential minimal reduction and antibody neutralization from these monoclonal therapies came from. But again, that was pretty cool. But if we come down here to figure 2, we see this very interesting data that I want us to take a look at. So we took a screenshot to pick out the biggest points from this data. Let's take a look at that. All right, guys, so what we did is we took a screenshot of that figure 2 and then just kind of blew it up with some points here that we really want to kind of hammer away within that article. So if we look here at this first cohort in part A, we have here this group that is unvaccinated but had been previously infected. And we're looking at kind of like 12 months afterwards and looking at their antibody neutralization capability. And we measure that via the ED50, the effective dose. And so what we can say here is that is the higher the ED50, the higher the neutralization capability. And then the vice versa, the lower the ED50, the lower the neutralization ability. So if we look here at those that were previously infected but unvaccinated, you see that their neutralization ability is relatively low. If we compare that to the group that had been previously infected and then vaccinated, we see how high that ED50 is with Delta. It's about how much more? About 4 times more potency, right? So there's a significant increase in antibody potency whenever there is at least a previous infection and only 1 dose. Actually, in this group, there's only 1 dose of the vaccine. So what we can see is a very significant increase in antibody potency. All right, so very interesting thing there. If we go to this next part of this study where we look at the Pfizer vaccine, week 3 and week 8, this is looking at only 1 dose of the Pfizer vaccine. This is looking at 2 doses of the Pfizer vaccine. Again, look at the ED50 here for Delta, really, really low. Almost below the minimal effective dose that we actually want, or the lowest effective dose, really. It's very, very low. Compare that to those who had 2 doses of the vaccine. There's a significant increase in antibody potency after 2 doses. Same thing with the AstraZeneca. What can we see here? Again, this is week 10, so only having 1 dose. This is week 16, 2 doses. We see here that there is a really low ED50 with only 1 dose and a significant increase in antibody potency whenever there is 2 doses of the vaccine. Now, here's something to take away. If you look at the ED50 here with 2 doses, looking at the ED50 here with 2 doses of these 2 vaccines and comparing it with the ED50 of those that had a previous infection and only 1 dose of the vaccine, the ED50 is actually higher in those that had a previous infection and only 1 dose of the vaccine. And we can see that here with this big point here, that 1 dose of the vaccine and a previous infection increases antibody potency more than 2 doses of the Pfizer AstraZeneca vaccine. So that brings about the question that we'll have to answer a little bit later. Does having a previous infection provide some natural immunity against the Delta infection to the point where it can actually reduce your risk of being reinfected? I think one of the big things to take away from this is that antibodies are not the end-all be-all of our immune system. We do have other aspects of our immune system that help us to fight off this virus, such as our T cells, right? So again, take that into consideration that we have T cells and B cells, not just these antibodies that are the components of our immune system to fight off this virus. But again, very interesting study here. All right, let's take a look at another article here, but particularly looking back at table 1 and up to date. That's going to be 8F. And let's just kind of look at a blanket statement for vaccine efficacy. So we're back at table 1 in that up to date article that we have here again, 8F. We see here again, Delta. We have our variant that we've talked about, the mutations, but what are we really looking at here? If we look at that known attributes here, look at this here that we've kind of boxed out. There's a potential modest to moderate reduction in vaccine effectiveness against what? Symptomatic COVID-19 infections. But we see that there is not a significant impact on vaccine effectiveness against severe disease, meaning that these vaccines are maybe not as great with blocking infection, but they're very good at blocking hospitalization and severe disease, which is very important. All right, that covers the vaccine efficacy. Let's talk about the next thing, which is going to be the point 9 within the document of references, where we'll talk about other ways that we can reduce or prevent this Delta variant from continuing to spread through the utilization of non-pharmaceutical interventions.
The next thing that's important here is that because vaccines aren't as great now with this Delta variant, right, with, again, reducing symptomatic disease or infection, we need to start instituting other levels to prevent the transmission of the virus. And what is that level that I think really needs to be reinstituted and more, mandated is wearing masks, non-pharmaceutical interventions, wearing masks when you're in large crowds, wearing a mask and trying to stay at home when you're actually exhibiting symptoms or when you test positive for COVID. Again, those are very important things. Washing your hands when you're touching a lot of surfaces, avoid touching your T-zone to increase the risk of spreading that virus. When you're at home, try to open up the windows, increase the ventilation through the actual house, and again, trying to maintain a particular social distancing, acceptable distance of greater than or equal to 6 feet away from someone else. And again, optimizing your immune system with vitamin D. These things to be things that we should really try to institute. And again, let's look at some data from the Leak CDC report that helps us with this.
All right, so let's talk about here again, this is 9A, this is a Leak CDC report. So we talked a lot about how vaccines are, again, there's less effectiveness of them against infection, mild symptomatic disease, but they're very good against hospitalization and death. Well, this is where we need other preventative measures. So if we go to that Leak CDC report, and we've already talked about a lot of this stuff already, but if we come down here to this part here in that Leak CDC report, we see here that given the increased transmissibility, the lower vaccine effectiveness, and the current vaccine coverage that we have, there needs to be more institution of NPIs, non-pharmaceutical interventions, to reduce the transmission of this nasty Delta variant. What does that mean? masking when you're in large crowds, masking when you're indoors, trying to stay away from large crowds, social distancing, maintaining a 6 feet distance, trying to wash your hands, avoid touching the T-zone that we've talked about before, ventilating your house, opening up the doors and the windows, maybe potentially getting more frequent testing. And so I think that these are big things. Optimizing your immune system with vitamin D. There's a lot of things that we should be doing that, again, aid in reducing this transmission of the Delta variant. And that's very, very important. And again, they have kind of a nice little summary statement here that NPIs, non-pharmaceutical interventions, are extremely essential to preventing the continued spread with this current vaccine coverage. Okay, so that's very, very important, something that we really need to take away from this with preventing the spread. And the last thing what I want to talk about is if you've been infected with the SARS-CoV-2 virus, potentially maybe one of the original ones, like the Alpha or one of the other variants, is there a risk of being reinfected? I think that's a good question to ask. And do we have natural immunity against it? Do we need to actually get vaccinated if we've been previously infected? So let's talk about that in the last point, point 10. We'll talk about that in the next part here.
All right, so the next question I really think I was curious about is if you've previously been infected with COVID. So you've had COVID, you've had some SARS-CoV-2 virus, whether it was one of the variants that we talked about, you've been infected with one of those. Your immunity that you build up against that virus, your natural immunity, is it enough that it could prevent you from being reinfected with this nasty variant, the Delta variant? And so what we have seen is some particular articles. One article that we'll talk about kind of says, I think you'll be good, there's a lower risk of reinfection, but it's an interesting article that looks at the time period when Alpha variant was the more prevalent one. And then we'll look at another one that kind of actually does suggest that there is a high risk of reinfection with the Delta variant, regardless if you've been infected in the past. So we'll take a look at that and understand that data. Let's take a look at that now.
All right, Engineer, so now let's talk about a very interesting thing, which is basically asking the question, does having some natural immunity, if you've previously been infected with the SARS-CoV-2 virus, well, depending upon what variant it is, do you have some natural immunity that would reduce your risk of being reinfected? And so there's an article here, again, within that description box, the link we provided, 10A, we're looking at the necessity of COVID-19 vaccination in previously infected individuals. And so this was done at the Cleveland Clinic. And what they did is they took about 52,238 employees. And out of this group, there was 1,359 subjects who were previously infected but unvaccinated, okay? And if we look at only that group that were previously infected and unvaccinated, how many of these individuals that were previously infected got reinfected with the SARS-CoV-2 virus? Well, if we look right here, it says 0. Out of that 1,359 individuals who were previously infected and unvaccinated developed a reinfection of COVID-19, or particularly SARS-CoV-2, over the duration of this study. Okay. Now, there's something we have to point out about this. When this study was done, it was primarily the Alpha variant that was the most prevalent during this time period. So this statement here does not apply to the Delta variant. We can't actually say that there is this ability to have, a reduced risk of reinfection based upon this study, because Alpha variant was the primary prevalent variant at this point in time. But something else that I found, again, just supporting vaccination, is if we look here, there was a particular amount of individuals that were not previously infected and were unvaccinated. And what did we see with that? There was a steady increase in cumulative incidence, in other words, those who developed either symptomatic disease or became infected with SARS-CoV-2, among those that were previously uninfected, so they had almost no natural immunity, and unvaccinated. So just, again, it supports the fact that you do need to be vaccinated, and vaccination does help in some way to reduce incidence of infection. Okay, so again, one of the big things to take away from this is that reinfection with this kind of article, when they're throwing it around, it was primarily when the Alpha variant was the most prevalent. If we look at another article, 10b, within that link that we provided you, that's going to take us to the Public Health of England Technical Briefing 19, which provides, again, some more support, though, about the Delta variant and reinfection. So let's take a look here at this Public Health England Technical Briefing 19. This is 10b within that description box link we gave you guys. If you go to the table of contents, for some reason this link doesn't work, so we're going to click on secondary attack rates here and then just scroll down to page 35. So if we scroll down here, there was, again, this reinfection kind of tab that we're going to be talking about. And what we have here is some data where it looks at the adjusted odds ratio of reinfection with the Delta variant. And what do we see here? The adjusted odds ratio of being reinfected with the Delta variant, there's about an overall 46% higher chance of being reinfected with the Delta in comparison to Alpha, and we can see that right here. Now, they also looked at a time frame, those that were infected less than 180 days and those that had a prior infection greater than or equal to 180 days. So if we compare that, that's around, if we wanted to really take an example here, that could be like January of this year. If you had been infected, again, greater than 180 days, it would have been around January. But if we look here, the risk of reinfection was not elevated for Delta if the primary infection was less than 180 days. So if we look at the adjusted odds ratio, it's really low. And so there's not a significant difference here when you compare it with Alpha. But if we look at those that were maybe infected about greater than 180 days ago, again, around January, what do we see? We see the adjusted odds ratio of about 2.37. That's about a 237% higher chance of reinfection in comparison to Alpha. And if you remember, what was the primary prevalent virus during that time period of about greater than or equal to 180 days around January? It was the Alpha variant. So there is a pretty high chance of reinfection. We see an overall higher chance of about 46% to get reinfected with the Delta virus. And again, that is very, very important. And so this shows that there is a chance of reinfection. Natural immunity is beneficial, but I don't think it's the end-all be-all. I think vaccination will definitely enhance your chance in reducing the incidence of symptomatic infection, as well as really reducing the chance of hospitalization and death. And we see that a lot from the data that we've provided.
All right, Ninja Nerds, so in this video, we talk about the Delta variant. I hope this video sheds some light, some understanding on the Delta variant, how severe it could potentially be, and how it seems that it will actually be the upcoming variant that we're going to see being the most significant one in the future here. I really urge you, I really suggest that you guys go down in the description box. We'll have a link there that'll take you to a document with all the references that we referred to throughout this video. Go read those. We tried to make it as easy as possible for you guys to be able to click and go exactly where you need on that document. But I urge you guys to read through them, sift through them if you want to know some more information about the Delta variant. Also, I think it's extremely important that you understand a lot of the information that we have on the Delta variant is new. We need a lot more studies. We need to do a lot more things to really truly understand and elucidate some of these significant points that we made about the Delta variant. So I think that as time comes and goes and we get more studies, more understanding of this Delta, hopefully we'll develop some good strategies, prevention, and treatment modalities for the Delta variant. All right, Ninja Nerds, stay safe, and as always, love you, thank you. Until next time.